I think I can start the class at this point of time. So, one of you please share that whether I am audible and visible.
Yes, sir, you are audible and
Dr.
visible, sir.
Damodaran, audible.
Okay, fine. So this is going to be a very basic class. I'll go with Tanglish, that is both Tamil and English, so that everybody are understanding what I am going to say, because it is going to be very basic. And this is the sort of a test run, because I am not expertised in doing the Zoom meeting, but at the same time, we have to ensure that everybody learns and everybody gets benefit out of it. So this is regarding the
Sir, your slides are not visible.
your slide. Is it visible now?
No. It is full screen slide. It must come full screen slide. Your face only we are seeing. You have to
Sir,
check.
slide is visible. Slide is visible, sir.
Slide is visible, sir.
Right. So now I'll go to the very basic on cardiology. For understanding ECG, you have to know the conduction system of the heart, right? So conduction system of the heart, as you can see here, there are 4 chambers, everybody knows. The right atrium, the upper part of the right atrium, we have the sinoatrial node. From there, the impulse gets connected to the atrioventricular AV node. From there, it comes to the His bundle, and through the right bundle and on the left bundle, it reaches both the left and right ventricle almost simultaneously, because the conduction system is very fast conducting. So this is the reason why there is a specialized conduction system. So the carry home message is very simple. You have got a specialized conduction system which conducts the electrical impulse very fast, so that both the ventricles are simultaneously innervated. Because it is simultaneously innervated, see, please, people do not mute yourself. It is disturbing everybody. So simultaneously, both the ventricles has to contract. Ventricle contraction, to make it very simple, துணியை காய போட்டு புளிகிற மாதிரி தான். So what it gets, it wrinkles the ventricle and the stroke output is occurring. So to happen this, there should be a simultaneous innervation. See, Sabas, people can people, please mute. It is disturbing my flow of thinking. It is easier for you. It is easier. It's not easier to have an interrupted class.
Hello. கேக்குதுங்களா? டிஸ்டர்ப் பண்றது யாரு? ஸ்டாப் பண்ணுங்க. Hello.
Vinita SA, please mute your mic. Vinita SA, please mute your mic.
கிரவுட்ல இருக்கிறவங்க, டிஸ்டர்பன்ஸ் பண்றவங்க தனியா ஒரு ரூமுக்கு போயிருங்க.
See, this is a very basic class. So for people who want to understand the ECG, I'm just trying to take the very basics. Then only we are going into the depth of ECG. So now I will continue. So we know that we are conducting from the SA node to the AV node. So from the SA node, and from there, bundle of His, right bundle, left bundle. I repeat it. From there, it goes to the Purkinje fibers, and all the things, both the ventricles are simultaneously innervated. Now I'll go a step further. I told you the conduction system is a specialized rapidly conducting system, whereas the muscle is not the same. So the another carry home message is muscle conduction is not the same. You can see the numbers here. From here, SA node to reach the AV node through the right atrium and the left atrium through the conduction pathways, muscle conduction. See here, it takes 0.07 seconds, right? So it takes around 0.07 seconds to reach from the SA node to AV node. This AV node is a speed breaker. Why the speed breaker should happen? Because, see, yes, once the atrium is getting innervated, it starts contracting. This contraction forces open the mitral and tricuspid valve, and the blood from the atrium reaches the ventricle. So there should be a time allowance for the blood from the left atrium and right atrium to reach the left ventricle and right ventricle. To happen this, there is a speed breaker in the AV node which slows down the conduction. You just see here, there is a AV node conduction is very, very slow. AV node conduction is very, very slow, so that it slows down the conduction between the atrium and ventricle to allow the atrium to empty the blood into the ventricles. So now the ventricle is filled. After ventricle is filled, see here, approximately 0.16 second from the SA node impulse, it reaches the bundle of His and right and left bundle, and within 0.16 seconds to 0.18 seconds to 0.2 seconds, it reaches the, see here, 0.23 seconds. It reaches both the ventricles, and within 0.05 seconds, completely the whole ventricle is innervated. This is because of the specialized conduction system. This might be difficult for beginners. It is very, very important. Specialized conduction system, conduction is very, very important for rapid propagation of the electrical impulse. Thereby, both the ventricles are simultaneously contracting. Right? Now, I'll make it much more easier. See here, from the SA node, it comes to the AV node, bundle of His, right bundle, left bundle, Purkinje fibers. See here, you can see the whole cycle. From here, 120 to 200 milliseconds is the time duration. From there on, it quickly comes to, from this place to the AV node to the Purkinje fiber, it takes another only 20-30 seconds to quickly go through because of the specialized conduction system. Now, coming to the more refining the same what I have told. The conduction through the specialized conduction system is much faster. I really emphasize because when I am going to talk about right bundle and left bundle branch block, these points are going to be very, very important. It conducts very fast through the bundle of His, conducts very fast through the right and left bundle. And once it reaches the Purkinje fibers and into the myocardium, the conduction system is becoming slower. And when it is not functioning, you can see there is an inherent rate with which every place is working. The SA node works around 60 to 100 per minute. Atrial pathways, that is in the atrium, it works around 55 to 60. AV node, when SA node is not functioning, it works around 45 to 50 beats per minute. In bundle of His, you call it, generally we call it as junctional rhythm, it works around 40 to 45. Ventricle fascicles, it works around to 40 to 55, right and left bundle. And Purkinje fibers, 35 to 40. Until now, there will be a stable rhythm, and beyond myocardium, beyond this, the myocardial will be an unstable rhythm, which will be white QRS complex, and the rate will be 30 to 35. So this is all very basic, which I want to make you understand. But over a period of time, whenever the class comes, the topic comes, this will be made easier for you to understand. So how do you want to interpret the whole ECG? That is simple. Whenever you are seeing a ECG, in the last 15 days or so, I always see people jumping to the diagnosis. Please do not jump to the diagnosis. That is not going to help us in fine-tuning the ECG knowledge as well as get the complete diagnosis, because obvious is obvious, inobvious is obvious. There will be some finding which will be, say, for example, ST elevation might be obvious, but we might be missing a complete heart block in inferior wall MI. So you have to systematically read the ECG. For that, what we need to do, we need to know whether what is the ECG type and recording. Then we need to assess the rate, rhythm, and axis. Then systematically we have to go. We have to go with the P wave, PR interval, QRS complex, whole in toto, ST segment, T wave, U wave, and the intervals, QT interval. And if at all, the next subsequently analyze the individual QRS complex like chamber hypertrophy. So this is how you have to go with the ECG. This is what the interpretation template will be like this. See here, ECG interpretation, the P wave, PR interval, QRS complex, QRS, QRS complex, ST segment, T wave, U wave. This keeps on coming. So before that, you have to understand the ECG paper. The ECG paper, if there is going to be a small squares, the small square is a small square is 0.04 seconds, and 5 small square is 0.2 seconds. That is 200 milliseconds. So see here the PR interval from P to the QRS complex, PR interval what we call will be approximately 5 up to 5 milliseconds, small squares, that is up to 200 milliseconds or 0.2 seconds. So this is what is the P and PR intervals, beginning of P to the PR interval, beginning of Q or R, whichever is earlier, will be called as PR interval. And you will see that 5 small squares makes around 200 milliseconds. So every small square is 0.04 milliseconds, 0.04 seconds, right? So next, what you need to do is, we are looking to is whether it is completely standardized or not. So how do you want to look at the standardization? See here, in every ECG, either in the left corner, left side, or in the right side, you will have this box-like features. So when you have a 5 square width and 2 big boxes, that is 10 small square height, that is a normal standardization. This is what the ECG paper is calibrated to record the ECG. But when the QRS complex is very large, you will always see the standardization becomes half standardization. That point of time, you will have the ECG, the standard calibration will be half, 50% of what is there. So whenever that is there, then you have to multiply the QRS complex by 2. So this is a simple thing. Sir, somebody can please switch off their mics.
என்னாச்சுன்னு கேட்ட சண்டை என்ன சண்டைன்னு திருட்டியா
Leo Bimaro.
எப்படியா ஒரு விஷயம்
Bimaro. Leo Bimaro, please. Leo Bimaro, please.
Sir, can anybody switch off your mics? So ECG, the calibration is very simple. You have to have 2 big squares or 10 small squares height and width of 5 small squares or 1 big square. That will be the normal calibration for the ECG. That means the ECG is recorded at a 25 millimeter per second ECG. So for practical purposes, we all record at 25 millimeter per second. If you want to decipher the arrhythmia, that is small P waves are there which we will recover, then we record the ECG at 50 millimeter per second, which is not the normal norm. If everybody records at 25 millimeter per second, so this is the calibration you have to understand, right? So you have to understand there is usually the calibration is showed here. The left side, you can see the calibration, which is 5 small square or 1 big square width and 2 big square or 10 small square height will be the calibration. If it is there, then we need not height and we can continue with it. So what next we will see is there will be a bottom. Usually a 12 lead ECG is taken. The current ECG machine, which is a much bigger, and this ECG in the bottom will have a long strip. We call it as rhythm strip. Sometimes it is simultaneously correlating with the ECG complex which is being recorded over there, or sometimes it is independently taken. This long strip, why this long strip is, the long strip will be helpful to analyze the arrhythmia, regularity of the QRS complex, regularity of the P wave, and if there is any absence or presence of P wave, everything can be seen and visualized best in the long strip. Usually the long strip is calibrated in the lead 2 or V1. These are the only two leads usually it is calibrated, right? So where do you want to place the lead? Conventionally, we take ECG in the chest leads from V1 to V6. Rarely we take record ECG in the right side, V3R, V4R, V5R, or in the left side, V7, V8, V9. So why do you going to do it? Why do you need to do it, and how are you going to do it? See, this is how the ECG will be looking like. See here, you are going to take the ECG, place the ECG in the fourth intercostal space. On the right side of the sternum is V1, left of the sternum is V2, at the apex is V4, between V2 and V4 is V3, lateral in the anterior axial line is V5, and in the mid axial line is V6. This is how you place the lead. And whenever you have a inferior wall MI, you want to record ECG on the right side. Similar on the left side, you place the V3R, V4R, and V5R. If there is going to be a posterior wall MI, we need to record it on the posterior side. Means we take V7, V8, V9, which I have a picture, and I will let you know. So this is how the V7, V8, V9 will look like. You got to go to the posterior axial line and scapular, mid-scapular and medial scapular line, and you have to record place the lead and take it, which is going to be tough. But if it is required and demonstrate the posterior wall MI, we need to take this. So as I was putting it earlier, how do you want to take it? See here, the ECG which I have placed it here, which is here. If you want to take a look at three-dimensional view of why, if you are placing the lead directly over the heart, how it will look like. See here, V1 will look like exactly in this place. V2 will be like this. V4 in the apex. Between V2 and V3, V4 there is a V3, and V5, V6 will be in the axillary lines, anterior and mid axial line. So this is how the ECG will be if you take if you place the lead exactly over the heart. So this is how the ECG will be looking like, and this will be useful in identifying the area of blood supply later on, which I will be describing during the acute coronary syndrome ECGs. So why do you want to take up the special leads like V7, V8, V9? See, this is the classic of lead to ST elevation is there, suggesting a inferior MI, and one and A, we have one is showing ST elevation, suggesting a lateral wall MI. So the same LCX territory can cause a posterior wall as well, which can cause ST elevation in V7, V8, and V9. So if you want to address it, we can always show this V7, V8, and V9. Somebody can stop talking.
Dr. Saravanan KP, please.
Sir, if people are not interested, please leave the meeting, because so many people are interested in leaving.
Sir, I'm the technical person. Please give me the host rights. I will manage.
Sir, somebody who's talking, please, if you are not interested, please leave the meeting. So many people are interested, and my flow is also getting disturbed.
Subramanian sir, I am the technical person. Please give me the host rights. I am the technical person. Please give me
Mr. Balamurugan, please mute. Balamurugan, please mute.
Sir, I am the technical person. Please give me the host rights. I will.
How do I give the host rights to you, sir?
Click on the sir. Click on
And please tell me, how do I give the
click on the on technical support, more option, host.
more after
Host. Technical support, more option, host.
more
option, host.
Host. More option, host.
Make a host.
I am not seeing anything.
Yeah, I will raise hand my side. Click on the more option. Click on my name and tap and click on the host rights.
Tech support is visible, sir. மேல தெரியுது
Huh?
sir.
சார் பார்ட்டிசிபென்ட்ஸ் லிஸ்ட்ல போனா டெக் சப்போர்ட்ங்கிற பேர் இருக்கும் சார். அந்த பேரை நம்ம கிளிக் பண்ணோம்னா மோர் ஆப்ஷன் வரும் சார். அதுல மறுபடியும் நம்ம அதுல வந்து மேக் ஹோஸ்ட் கொடுத்தோம்னா வந்துடும் சார்.
Make hostங்களா?
ஆமா சார், அது கொடுக்கணும் சார்.
Yes, sir. I already raised hand.
இல்ல,
பார்ட்டிசிபென்ட் லிஸ்ட்ல
I'm
போனா
not
டெக்
getting.
சப்போர்ட் வந்துட்டு ஹேண்ட் ரைஸ் பண்ணிருப்பா சார். அவரோட சிம்பிள் இருக்கும் பாருங்க சார்.
Click,
அந்த
click on
பார்ட்டிசிபென்ட்ஸ் லிஸ்ட் இருக்குல்ல சார்.
Participant listல
அந்த
the,
லிஸ்ட்ல
yes,
போனீங்கன்னா டெக் சப்போர்ட்ங்கிற நேம் வரும் பாருங்க சார்.
raise hand. I already raised hand. My
அவரோட கை
name
ரைஸ்
is-
பண்ணிருப்பாரு பாருங்க சார். ஒரு ஹேண்ட் சிம்பிள் இருக்கும் பாருங்க சார். அவர்
tech
நேம்
support.
அதை கிளிக் பண்ணும் சார். கிளிக் பண்ணதுக்கு அப்புறம் மோர்
Okay, tech
ஆப்ஷன்ஸ்
supportல.
Yes, sir.
அதை
Yes.
கிளிக் பண்ணுங்க சார்.
Okay.
அதுக்கப்புறம்
host.
அதுல வந்து மோர் ஆப்ஷன்ஸ் கிளிக் பண்ணி
Make
மேக்
host.
ஹோஸ்ட்
Right, sir. Yeah. Thank you, sir. Thank you. I will manage.
அவ்வளவுதான் சார். இப்போ அவர் எல்லாத்தையும் மியூட் பண்ணிடுவாரு சார்.
இப்ப screen sharingல இதாயிடுச்சு.
I will give the.
Somebody has to give me the screen sharing.
Yes, sir. One sec.
Technical person, can you give me the screen
Yeah.
sharing option?
Yeah. 1 sec, sir. Yeah, done, sir. Done.
Okay, now thank you for allowing me to do it. Right. So now we are there. Now I don't have any headaches. We can proceed with the presentation, I believe. So B7, B8, B9 is used in recording the posterior MI in presence of infrolateral, inferior posterior or posterolateral MI. This is the special situation. The next situation where you have it is in right ventricular MI, where you need to record the right ventricular MI, means we need to place the electrode in the V3R, V4R and V5R and record the ECG on the right side, which will show ST elevation in presence of inferior posterior MI, where your management, it indicates that the occlusion is in the proximal right coronary artery before the right ventricular branch, and the treatment management is totally different from the distal RC occlusion. That's the reason why we need to record V3R, V4R. So this is how you have to place. So these are all minor technical details we need to understand. So today also in the cardiac group, we were discussing about the limb lead changes in the ECG, where how it look like. We'll see what exactly is there. So we'll go with the rate, rhythm and axis today's class. So this is the proper today's class. We'll go with the rate. How are you going to calculate the rate? So now again we'll see the one small square is equal to 0.04 second. This is 40 millisecond, and 5 small squares will make one big square, and that will be around 200 milliseconds. So this is how we got to basic understanding. Then we'll start calculating the rate. So if you want to calculate the rate, if you are taking the small squares, number of small square, 500 divided by small squares, that is R interval small square, you will have the one rate. Or if you are going to take the large square, 300 divided by the RR. Now we will see this rate. See here, this is the big square, that is the darker mark is the big square, whereas the lighter mark is the small square. So 300 divided by the big square. So between these two RR interval, we can see 1, 2, 3. I am marking in the lead 1, 3, 4 and 4 and slightly above. So approximately 4 between the RR, that is 4 big squares are there. 300 divided by 4 big square is 75. So here the rate will be around 75. That's all. If you want to take the small square, so every small square you have 5 big square, 1 big square, 5 small squares. 5, 10, 20, 25, 26. So 1500 divided by 26, approximately again 75, 80. So this is how you have to calculate the rate. So calculating rate is whenever more than 100, you call it as tachycardia, more than 50, less than 50, you call it as 60, you call it as bradycardia. So the approximate rate is sufficient in most occasions, except for situation where atrial fibrillation to calculate the rate, average rate, we require more accurate calculation. So here roughly 300 divided by 4 big squares, it is around 75 per minute. A simple way of calculating the rate. So more important than the rate is the rhythm, whether it is regular or not. So for that, we have to understand what is sinus rhythm. Sinus rhythm. So this is a simple carry home message. Sinus rhythm. Every P wave is followed by a QRS complex. See here, I'll come with this is most important carry home message. Whenever you want to see the ECG, every P wave is followed by a QRS complex. Right? It is happening here. Every P wave and PP interval is fixed. See here, the PP interval here is fixed. The one P wave, the next P wave, it is fixed. One P wave, next P wave is fixed. So P wave is constant. P wave coming. Every P wave is followed by a QRS complex. And the P wave, the next P wave is expected to come, means it is exactly coming in the same place. It is fixed. Right? So the P wave is upright in lead 1. See here, P wave is upright in lead 1. Next is P wave is inverted in AVR. P wave is inverted in AVR. Now you can know P wave is upright in lead 1. P wave is inverted in AVR. Every P wave is followed by a QRS complex. All P waves are fixed. PP interval is fixed and every P wave falls on the expected place. So if this is happening, then it is sinus rhythm. So this is the most important part in starting the ECG analysis. Patient, whether the SA node is acting or not, then only we can call it as sinus rhythm. For that, you have to understand this point. P wave is followed by a QRS complex. PP interval is fixed. P wave is upright in lead 1. P wave is inverted in AVR. Right? Now we will see a classic example. Look at the P wave here. So there is no P wave in lead 1. So no P wave in lead 1, no P wave in AVR. So it means sinus node is not functioning. Simple. Yes, simple first ECG, first step in look into your ECG will give you a simple answer. P wave is not there. So it means sinus node is not functioning. Then look at the QRS complex. QRS complex, go to the rhythm strip. Once you have wanted, go to the rhythm strip at the bottom. You can see the rhythm strip. P wave is not, RR QRS complex is not regular. There is multiple QRS complexes are coming. It is not regular. That means that patient is having atrial fibrillation. Absent P wave, QRS complex is not regular. Simple diagnosis atrial fibrillation. You need not bother about looking into whole ECG. Simple P wave absent in AV lead 1. P wave is not upright in lead 1. P wave is not there in AVR. P wave is not inverted in AVR. Then you have to look into the QRS. QRS is irregular, absent P wave, straightforward diagnosis of atrial fibrillation. Now here is a different problem. There are some leads with the ECG. The ECG is showing P wave is preceding the QRS complex. See here, the lead 2, the P wave is there, but it is preceding the QRS complex, followed by a QRS complex here. But lead 1, there is no P wave at all. You are not seeing a proper P wave in lead 1. It means that the lead wave, possibly the lead one place it is there, it is not there, and it is equiphasic. So here lead 1, you are not having upright QRS, upright P wave. That means it is not in sinus rhythm. That is not from the SA node. See here in AVR, P wave is upright. It should be inverted. P wave inverted, it is upright, means it is not from the sinus node. Simple. So your must diagnosis, whether in sinus rhythm or not, upright P wave in lead 1, it is not there. Inverted P wave in AVR, it is not there. It means that patient has got, doesn't have the sinus rhythm. It is something else. This simple, this for people who are curious why it is inverted, because the ectopic atrial rhythm is happening. It is happening in the lower part of the QRS atrium. That is why it is inverted. I will tell you why it is inverted. So this ECG tells you the patient is not in sinus rhythm. Next, going to the axis. This is another time consuming. I'll take 10 minutes. I'll patiently explain to you how it is happening there. See here, the heart is lying in the, like this, obliquely from the right towards the left. Obliquely right towards left. SA node is in the right top. See here, SA node is in the right side on the top. And from there, SA node to the AV node. I see the arrow mark which I am marking. SA node to the AV node. From there, it bundle of his and comes to the ventricle. See the direction from the right side. I write SA node right atrium towards the left ventricle apex. So it comes from the right side to the bottom left. So this is how the axis of the electrical axis goes. So it means that it is going the right upper right SA node to the LV apex from right side to left. So this is the normal axis. See here, the normal will be between approximately 30 to 60 will be the normal axis for most of the people. Most of the people, when the heart is obliquely placed. Suppose a thin individual and the heart is vertical placed, it will be around 60, 70 or 90. Or in an obese individual, when his heart is slightly on the horizontal place, it will go up to minus 30. Now you know why it is different. So one people will be there. Most of the people will have axis between 30 and 60 degree because heart is obliquely placed. This is how it will be there. From SA node, the heart is connected towards the left ventricle apex. That is the reason why the axis is towards apex and it is between 30 to 60. Now you need to understand this point. And the next point is, whenever there is a vertical heart, slightly vertical heart, the heart will be more straight. At that point of time, you will see the heart axis is directed towards 70, 80, 90 degree. Up to that is normal. Whereas heart is slightly horizontal because of the obesity or something like that, you will have, or any electrical abnormality, you will have the axis directed towards the left and it is slightly horizontal, say 0 degree, minus 10, minus 20. So this is the normal axis for most of the individual. Sometimes you will have right axis deviation, left axis deviation. So what is right axis deviation, left axis deviation? Now you see the normal axis where exactly is there. I am differentiating with the color. See here, the normal axis most of the time will be between 30 and 60 degree. And when it is sometimes it can extend up to plus 90 and minus 30. This will be the normal axis. The heart is lying like this in this plane, obliquely. And if you are going to take the ECG, now you will need to know the ECG, why I am taking about the correlating with the ECG and the electrical leads. Now imagine I am standing with my arms stretched outwards like this. So when I am stretching out the arms like this, the left upper limb is called AVL. Right upper limb is called AVR. And the right bottom lower limbs is called AVF. Right? So this again carrying a message. You got to understand. Left upper limb is as L. L is the AVL. Left upper limb is AVL. L is there for left upper limb. And for right upper limb, it is AVR. And for lower limb, it is AVF. Right? You understand the AVR, AVL, AVF concept. Right? Now, you have got other leads. 1, 2, and 3. Left between the right. Instead of that, you make it simple. Left upper limb, you will have below the left upper limb, in the left side, exactly on the stretching of the limb, you will have lead 1. This is 0 degree. Lead 1 is 0 degree. And exactly opposite is from 0 clockwise. If you rotate, in the positive side is up to 180. From 0 to the negative side, it is minus 180 degree. And you are having between these two, every 60 degree, there will be a shift with the lead 2 will be there plus 60 and lead 3 is plus 120 For convenience sake, memorize over a period of time, you will understand. I will also explain to you how this comes. So it is making it more simple. AVF is foot, F stands for foot, left upper limb stands for AVL, right upper limb stands for AVR, and the lead 1 stands for 0 degree, lead 2 stands for 60 degree, lead 3 stands for 120 degree. Now I will say this, the normal axis, most of the time, lead 2 is the 60 degree is the towards the axis is towards my plus 60. So every time in the limb leads, you will always have lead 2 as the tallest of all complexes, because the most of the time QRS complex axis is directed towards my plus 30 to plus 60 degree. That is the reason why lead 2 will be the tallest of all the complexes. If you happen to see, AVR will be always negative because the electrical impulses goes from the away from the electrode, which I'll say. So so now you will see the axis AVR will always be negative because you will have the from the SA node, the electric impulses are conducted towards the left ventricle apex, so that from AVR, இது வந்து சிம்பிளா டார்ச் அடிச்சு பாக்குற மாட்டா, AVR ல இருந்து டார்ச் அடிச்சு பாக்குறது. So AVR ல இருந்து டார்ச் அடிச்சு பார்த்தா என்ன ஆகுது? It is away from the electrode. Once it is away from the electrode, every electrode which is away means electric activity away from the electrode will always record it as a negative potential. So this negative potential will be recorded when it is away from the electrode. So AVR will be negative and towards the electrode will always be positive. So lead 2 will always be positive. Now you understand why AVR is negative and lead 1 is always positive, because from lead AVR, the SA node, from here the conduction happens, from here towards, it conducts towards the lead 1. So when it happens, the conduction electric activity goes towards lead 1, it is always positive. That is the reason in sinus impulse, lead 1 will always be positive, and in sinus rhythm, AVR will always, P wave in AVR will always be negative. So that's the reason why in sinus rhythm definition, P wave is upright in lead 1, P wave is inverted in AVR. This is the reason. And because it is going away from the electrode, right? So here you see the normal axis. See here I was telling about towards 60 degree, that is lead 2. You will always find the QRS axis is the QR, whichever is the tallest QRS, you think it is the axis. So it is, this is now you are making simple. Lead 2 as the tallest QRS, think it is an axis. So it is most of the time it is the tallest QRS, it is the axis and it is normal axis. You will see the subsequent example. Next way of understanding the axis is, whenever there is going to be a equiphasic in some QRS complex, take it the perpendicularly. See here in AVL, it is equiphasic, and exactly opposite to that. In AVR, you will have predominantly positive QRS complex. Then mean you have to take this as equiphasic complex, and that is the axis for the patient. Whenever there is going to be a left axis deviation, you will have something else. Left axis deviation is beyond, this is LED, left axis deviation. This is where up to minus 30 to plus 90 is normal. Beyond that, from minus 30 to minus 90, we call it as left axis. And plus 120 to plus 180, we call it as right axis. What will happen when it is minus 30 to minus 90? So lead 1, see here, minus 30 to minus, lead 1 is positive. Lead 1 is positive. So see the QRS, lead 1 is positive. So it is in this half. This half. Lead 1 is positive. Lead 2 is negative. So lead 2 is positive this side, whereas lead 2 is negative. So it is on the opposite side. AVF is negative. So it means that it is on the opposite side. See here, AVF positive is on the foot. So it is away from the foot side. AVF is negative, sir. From electrical activity from this area, it goes away from the foot side. So that is the reason why it is negative. So I told you, every electrical activity will be directed whenever there is towards the electrode, it will be positive. Away from the electrode, it is negative. That is another carry message. Towards the electrode, it is always positive. Away from the electrode, it is always negative. AVF, it is negative, means away from the electrode, it is negative. So you are having AVF here, lead to negative, AVF negative, QRS complex negative, and patient will have in total, when you accumulate all these things put together, you will have a left axis deviation between QRS axis between -30 to -90. See here, the lead to negativity. So to make you understand, there is a picture, but whenever there is you are having a lead to negativity and AVF negativity, to an AVF negativity, it means the patient has got a left axis deviation. As simple as that. Lead one positivity and lead to negativity and AVF negativity, it is left axis deviation. See the example here. Lead 1, it is positive. Lead 2, it is negative. AVF, it is negative. Lead 1 positive. AVF, lead 2 negative. AVF negative. Simple. Forget about the rest of the ECG. So patient has got a left axis deviation. Simple. See this ECG here. Here instead of lead 1 negative, here lead 1 is negative. It means it is going away from the lead 1. So lead 1 positivity is in this side. Away from the lead 1 means negative, means it is going in this direction, this half. Lead 2 is positive, so it is in this half, positive half. AVF is positive. See this half. Putting all these forces together, we understand it is going towards +90 to +150. இந்த மூணு கலரையும் சேர்த்து ஒன்னா இருக்க ஒரு கலர் பாத்தீங்கன்னா இட் இஸ் ரைட் ஆக்சிஸ். ஸோ ரைட் ஆக்சிஸ்ல லீட் 1 வில் நெகட்டிவ், லீட் 1ல நெகட்டிவா இருந்து அப்ரைட் பி வேவ் இருக்கு. பி வேவுக்கு இதுக்கு சம்பந்தம் கிடையாது. QRS காம்ப்ளெக்ஸ் இஸ் நெகட்டிவ் இன் லீட் 1. லீட் 1ஓட பாசிட்டிவிட்டி இந்த 0 டிகிரி லெஃப்ட் அப்பர் லிம் அது பக்கம் தான் இருக்கு. ஸோ லீட் 1ஓட நெகட்டிவிட்டி ஆன் த எக்ஸாக்ட்லி ஆப்போசிட். ஸோ லீட் 2 இஸ் பாசிட்டிவ் ஹியர், லீட் 3 இஸ் பாசிட்டிவ் ஹியர். Putting all these forces together, you will find +90 to +150 is your axis. So this is right axis deviation. So here this is the example. Lead 1 is negative. Lead 2 and lead 2 is positive. AVF is positive. That's all. You call this as right axis deviation. See another example. See here, lead 1 is negative. Lead 2 and AVF is positive. Your patient has got right axis deviation. So we stop with this. And this class, we understand this is right axis deviation and left. So I'll summarize quickly. One carry home message is electrical current towards the electrode is always positive. So anything towards the electrode is always positive. So நம்ம மேல வந்து ECG எங்க வச்சாலும் இப்ப left upper limb பக்கத்துல போனா it is positive. Lead 1 will be positive. AVL will be positive. So a current going from top to bottom, SA node to the LV apical impulse towards the inferior. That means AVF will always be positive. Lead 2 is 60 degree. So towards the 60 degree normal axis, it is always positive. Any electrical current away from the electrode is always will be negative. So anything from SA node towards the LV apex, AVR is in the right upper limb. So this will be every electrical activity. It is AVR length torch அடிக்கிற மாதிரி, right upper limb torch அடிக்கிற மாதிரி. Electrical activity goes away from the electrode. So PVA will be negative here. AVR la QRS complex will also be negative. Simple. When AVR, whenever there is perpendicular to these two leads, so SA node LV apex வரைக்கும் there is a current going. The lead AVL what will happen to the AVL? It is exactly perpendicular. You just imagine, put it in your heart. See, from AV, right from the, when there is going to be a, diagonally one lead is coming like this, and you are going to have a exactly perpendicular lead like a AVL, that will be the equiphasic. Most of the time in sinus rhythm, P wave will be upright in lead 1, P wave will be inverted in AVR. Most of the time, you will have tallest QRS complex in lead 2, equiphasic complex in AVL. This is the most of the time. Whenever you are going to have a right axis deviation, you will have lead 1 which is negative, right axis deviation, lead 1 will be negative, and 2, 3 AVF, 2 and AVF will be positive, right axis deviation. See here, lead 1 will be negative, 2 and AVF will be positive, right axis deviation. Simple. Do not, for the next 1 week, this is the only exercise I want you to do. See, everybody keep changing, whether the patient is in sinus rhythm or not. P wave upright in lead 1 and inverted in AVR. Simple. It is in sinus rhythm. PP is constant and fixed, and every time the P wave is on the expected time, it is coming. And whenever there is going to be a tallest complex in lead 2, then it means the patient is in sinus rhythm. Lead 1 negative, lead 2 and AVF is positive, patient has got a right axis deviation. When the patient is having left axis deviation, you will have exactly the opposite, where you will see here, lead 1 is positive because it is towards the left side. It is positive, and lead 2 and AVF are going to be negative side. Negative means predominantly the QRS complex is negative. Predominantly the QRS complex negative. And that is lead 1 is predominantly towards the complex. Lead 1 means it is left axis. Towards lead AVF, lead 3 or AVF means it is right axis. As simple as that. And towards lead 2 is QRS complex is, it means that the patient has got a normal QRS axis. Whichever the axis there, the height of the QRS complex, height of the R wave will be the tallest. As simple as that. And to make the rate and rhythm, whenever you are not finding the P wave in QR in lead 1, look for other leads. See here in typical example, here you are having in lead 1, you are not having a P wave, but you are having P wave in AVR, which is inverted. It is not normal, it is upright. So it means it is not normal sinus rhythm, and you are having inverted P. So by not having a P wave in lead 1, doesn't mean that it is not in sinus rhythm. It is because of the equiphasicity in the lead 1, which is causing the apparent absence of P wave. But most of the time it is present. Whenever there is complete absence of P wave in all leads, see here in no lead there is no obvious P wave, and in lead V1 there is a fibrillatory wave, and RR interval is irregular. It means there is absent P wave, RR interval irregular. It means that you are dealing with the atrial fibrillation. This is the sinus rhythm where you are dealing with a P wave upright in lead 1. A P wave in QRS complex, P wave is every P wave is followed by a QRS complex, and P wave falls on the expected time. PP interval is constant, RR interval is constant, everything is constant. Then we think it is a normal sinus rhythm. So by this, I assume that you understood the rate rhythm, and the special leads is V5, V7, V8, V6 to record the posterior leads, and for recording the right ventricular MI, we need to record V3R, V4R, or V5R. So now I'll stop sharing the session, and we can have 10 minutes of discussion, I believe. You can unmute and start to get discussing. If there is any small questions or anything, I can share it now, and probably we will be more professional in the next class for making you more understand. Technical support can unmute the whole people.
Okay, sir. It's done, sir.
all the participants, you can unmute from your side, and after the question, you can mute yourself.
Sir, shall I ask, sir?
Please, sir. We have got little time. Please.
In which conditions we get right axis deviation and left axis deviation, sir?
Sir,
Conditions which we get right axis deviation and left axis deviations.
sir, I'm not getting you, sir. Please, கொஞ்சம் கரெக்டா சொல்லுங்க சார். தெரியாத புரியலங்க சார்.
Sir, in which condition we get the right axis deviation and left axis deviations, sir?
சார் அது புரியுதுங்க சார். சார் எல்லாமே பின்னாடி சப்சிக்வெண்ட் கிளாஸ்ல நம்ம பார்க்கலாங்க சார். இது வந்து ஐ எம் ஜஸ்ட் இன்ட்ரோடியூசிங் வாட் இஸ் ரைட் ஆக்சிஸ் டிவியேஷன், வாட் இஸ் லெஃப்ட் ஆக்சிஸ் டிவியேஷன், வாட் இஸ் நார்மல் ஆக்சிஸ், வாட் இஸ் ரேட் அண்ட் வெதர் இட் இஸ் ரெகுலர் ஆர் நாட். அவ்வளவுதாங்க சார். So this is a basic introductory class. I'm just putting you into the ECG so that in the subsequent classes we'll always describe whenever there is going to be.
Okay, sir. Thank you, sir.
Thank you so much.
Sir, excellent, sir. Very good, useful class for me, sir.
Yes, sir. Sir, this is purely basic. I have not gone into anything because I want to pull everybody along with me so that the subsequent classes, which is going to be more complex and going to be difficult to understand, the bottom line basic is every ECG, you have to understand the conduction system. The conduction system is very, very important. Once you understand the conduction system, and only 2 points, SA node, AV node, bundle of his right and left bundle, Purkinje system. That's all. Towards the electrode, it is positive. Away from the electrode, is negative. And imagine the axis, lead 1 and AVL on the left side. When it is QRS complex on the taller side, on these two, possibly you are dealing with a left axis. Lead 2, it is taller, we are dealing with a normal axis. Lead 3, which is taller, possibly we are dealing with a right axis. Upright P wave in lead 1 and inverted P wave in AVR. Okay. We are dealing with a normal sinus system. As simple as that. This class is very much precise only to understand these points. Once we understand this point, we'll go to the subsequent management of all the ECGs like QRS complex, everything we P wave, PR interval, QRS complex, ST segment, and all the intervals we can see. So subsequently, once we understand the QRS complex, how to evolve the QRS complex in chest leads, how progression of R wave happens, how regression of S wave happens in chest leads, how the QRS complex height we have to calculate, everything we will see one by one. So for that, the basic is very simple. You have to understand the conduction system, axis, how to calculate the rate, how to calculate the rhythm. That's all. Is there any doubt regarding this?
Very clear, sir. Hope our patients will be benefited from your future classes. Thank you, sir.
Thank you very much. This is very basic. I'll try to refine the possibly maybe more professional subsequently, where a lot of disturbance where my flow was completely disrupted. So subsequently we'll make it more professional, and probably I have learned something from the technical support also, how to mute everybody so that it becomes a full flow, and the class also becomes useful to everybody. And you can always put up your doubts in the forum, and I will keep explaining everything in detail, so that subsequently we'll go to the clinical conditions in the later on in the subsequent classes.
Thank you, sir. Good night, sir.
Is there anything more we need to understand?
Thank you, sir. It is very clear, sir. Thank you.
Right. If there is no more questions or discussion, we'll wind up it. And subsequently, you can give your inputs about how to further make this class better. And we'll further next week, we'll be having on intervals, PR interval, QRS interval, QT interval, and all the intervals we'll be seeing. And subsequently, the next class will be how the evolution of QRS complex. Next week will be ST segment deviation, how it is positive, how it is elevation happen, how negative depression happens. Every day, every week we'll evolve the ECG. And finally, at the end of 1 month, we should be learning to read a better ECG. And from there on, we'll go to the clinical condition and correlation. Thank you very much for everybody's patient hearing. Thank you.
Meeting is concluded. Can we end the meeting now?